For our second presentation of this session, can I introduce Professor Martin Vernon. He's the National Clinical Director for Older People and Person-Centred Integrated Care with NHS England, and we're very much looking forward to welcoming him to the stage. Thanks, Martin.
Thank you very much. I have the second longest title at NHS England. The longest goes to my colleague, Associate National Clinical Director Dawn Moody. We work together very closely. I'm just going to say first off that my Twitter handle is @runnermandoc. I'm a runner, I come from Manchester, and I'm a medic. That's a shameless attempt to increase my Twitter footprint, but also we use Twitter a lot to get some of the key messages out that I'm going to try and get through in the unenviable 15 minutes I have to tell you how to address the problems of an ageing population. So here we go. We're aware of this. I just want to quickly say that the ageing population is also, I think, importantly about numbers. The likelihood that you will survive into later life is increasing day on day. If you survive this meeting, you will get the 5 hours that you spent here back tomorrow because your life expectancy is going up at that kind of rate. That means that there will be more absolute numbers older people in society than ever before. There are also more generations alive at the same time than ever before. This is a worldwide phenomenon, and it's not just an issue about older people, it's also there are fewer entrants into the population at the lower strata as well. So the whole population is shifting upwards in terms of its age profile. That has some significant impacts. More people living with multiple long-term conditions, increasing amounts of complexity. All of these things will continue, and that is having at least some impacts on driving urgent and emergency care. People presenting with 5, 10, 15 long-term conditions into an emergency department cannot be sorted out in a short time scale. So where do we need to get to? And this, and I'm very pleased to follow Susan actually, because it's exactly the same messages that I'm going to be putting forwards really. It's about, to a large extent, prevention. We have to keep the working age population fit and healthy through losing weight, stop smoking, stop drinking alcohol, regular exercise. All of those things will enable you to engage in active and healthy ageing because we all age. That is an inevitability. But we also need to concentrate on the upper strata, the traditional post-retirement population, because those are also our workforce of the future. Increasingly, people will find themselves wanting to continue or being left with the responsibilities of continuing to work, contribute to the economy, but also provide unpaid care. We need to keep those people engaged and fit too. So if you come to Manchester, I strongly recommend you do. It's a fine city, and we have the habit of painting on walls. And this signifies really the intention that we have to think really hard about how we do this. And I would urge you to think carefully and choose wisely when addressing the needs of an older population, because we cannot do it all in one go. This sometimes gets put forward as a slide of doom, the reductions in numbers of acute care beds, but picking up on Bruce Keogh's message this morning, to some extent this, I think, illustrates the fact we've become increasingly efficient in the delivery of acute health care. However, I don't think any of us would want to deny the fact that that is also putting an increasing demand on the social care system. We spend a lot of money on older people's care services, but at the moment, in particular in acute care, the majority of that concentrates on providing bed-based care in hospital, and there is comparatively little spent at the front end and the interfaces of hospital, either around admissions and the first 72 hours of the pathway, and also towards the end of care. Just want to highlight this, and I would strongly recommend that you look at the data that's come out this year from the Old People's Acute Care Settings benchmarking audit. It's freely available online. Just to point out that the delayed transfer care problem is not quite what we think it is. At least a third of the problem relates to downstream management and waiting for NHS care services. Much of that is recovery and rehabilitation and community services. A third of it is social care, And a third of it is difficult, complex decision-making between families, clinicians, and other parts of the care system. I think what this says is that we have to put an increasing presence of older people's services in a community setting to compensate for that shift of care into the acute care system where it's causing delays. So taking forward the 5-year forward view, I picked up on this a year ago when I came into post and picked out the bits that were of greatest interest to me. This is about integrating services. It's about using the word frailty, the term frailty, and the condition, most importantly, effectively. And I want to persuade you that our approach to this will, I think, be game-changing in the NHS over the next 20 or 30 years. But this is not just about now. As Susan was saying, these are long-term issues. We cannot suddenly fix the system for older people to provide safe and effective care in a way that we would want to see in the future going forwards. We have to do this incrementally and slowly to ensure that we continue to meet the needs of the most needy as and when they require our support. The only way that I can envisage doing that is to engage in prevention, so to encourage and support active and healthy ageing, but also to continue to maintain a safe and effective system to deal with the consequences of either inevitable biological ageing or poor quality ageing for those who've had the misfortune to acquire multiple long-term conditions. So what is frailty? Effectively, we have characterised this in NHS England as a biomedical condition which persists in the long term and is due to the acquisition of multiple healthcare deficits. Why is that important? Because we record routinely, and have done so for many years, healthcare deficits in the electronic healthcare records that are prevalent throughout general practice. Having accumulated a number of deficits, somebody can undergo an acute stressor event such as a fall, a minor injury, an acute, apparently incongruous illness, and suddenly move from being independent to fully dependent. And the recovery is often delayed, unpredictable, and in some cases incomplete. That catastrophic change occurs daily when people present to the emergency services. The question is, can we get ahead of that and plan for those individuals before they reach that crunch point? If we go looking around, this is from the English Longitudinal Ageing Study, in society, frailty in its advanced state is easy to spot. These are defunctioned people who often require assistance with walking, moving around, require help with their personal and social care. And the prevalence of that is around 1 in 7 in the plus 60 age group. But that means that the rest of those older people are actually quite fit. Picking out the ones that we need to concentrate upon and organising their care around them effectively is therefore something of a challenge, given that I have roughly 10 million people in scope on my brief alone. Put another way, if people are losing resilience, they're going to need increasing amounts of care and support, and that's a very personalised issue for them. Some people manage their long-term conditions themselves very effectively, others need greater amounts of care and support. Some of that will be socialised care, some of that will be medicalised. Where you lie on that spectrum and how close you are towards needing more care and support than healthcare intervention very much depends on your level of resilience. So we're now characterising frailty as a long-term condition, not the defunctioned frail elderly, a term that I would like to see banished from the lexicon of health language, which really describes somebody who's reached the end point of this condition. What we're interested in is characterising this as a condition which we can spot early, we can plan for, we can manage, we can provide support and choice, importantly, around what matters to people. So that when they do eventually start to need greater amounts of healthcare and support, that is planned for and anticipated. So it changes the script about how we approach those people who are most at risk of acquiring frailty. As I've already said, not everybody who is old is frail, and not all frail people are old. In fact, frailty as a condition worldwide has been described from mid-teens onwards. This is not just about older people. So to prevent, we need to get upstream of that. We need to spot people early who are at greatest risk. And what we've been doing over the last year is promoting routine frailty identification, and that gives us an opportunity to risk stratify not by present and historical demand, but also by future anticipated need. That means that we can then start to target optimal interventions to enable those people to age well, to remain productive and active and connected partners in society. So are there preventable things? Well, there are in fact quite a large number, and this is all very straightforward stuff. And we need to, if for no other reason, and we all want to live a bit longer and live healthy and productive lives, not lives with disability, then this is one way to go about it. What we've now got is a validated system in the NHS, and we are unique in the world to have this. Effectively, it takes all of the read-coded data from thousands of items that sit within the electronic healthcare record, moves them into 36 deficits. The more deficits you have, the more frail you are likely to be, and the more likely, therefore, you are to present in crisis. So it's a predictive model. There's more to do with this, there's more refinement. It's highly sensitive, and it will pick up people who are not necessarily frail. So in order to operationalise this, we need to go through a series of processes. But what it does tell us is if you're mildly frail, you're twice as likely in that year to die, enter a care home or enter the urgent care system. If you're severely frail, those risks quintuple compared to somebody at the same age. In other words, you can stratify your population by anticipated future need over the coming years, and importantly, in the year ahead of you. What we've done is to put this into the GMS GP core contract for 2017-18. This was agreed in February this year. It's in the contract now. The recommendation is that we use the electronic frailty index because that is the most effective and easy way of identifying population frailty locally. It's available in all three of the following systems: System 1, EMIS, and the other one's gone out in my head for a moment, Vision, and Microtest are working on it. They've all operationalised it slightly differently, but effectively the index tells you the same thing. I'll point out this is a population screening tool. It requires second level validation. I have had people turn up in my clinic who would appear frail on paper and who are in fact turning up in running shoes. What we're asking in the contract for this year is that those people identified with moderate and severe frailty are coded, they're given a diagnosis. We can discuss what that actually means, but for those people with severe frailty, that we are also engaging in the first step of identifying their falls risk and optimising their medications. Importantly, we're also asking for those data items to be interoperated via the enriched summary care record, and we're also intending to extract that data nationally because at the moment we do not know exactly what the footprint of frailty looks like across the country by STP, by CCG, by geographical areas. So in order to check the person in front of you, there's a variety of validated tools. This is one of them. The Clinical Frailty Scale gives you an effective way of looking at that person and deciding whether or not they are indeed frail and by what degree. The data I've talked about, I'm going to skip over that. Why are we talking about falls? If you do nothing else, I would strongly suggest that falls prevention is an important and key step to take. We have NICE Clinical Guideline 161, I would strongly commend it to you, along with Quality Standard 86, and also there is a National Falls Consensus Statement which tells you effectively what is the best evidence in terms of interventions and prevention. Put simply, bone health and strengthening for those people who are most at risk and eligible for bone health management, but also strength and balance improvement. Falls because they kill, they lead to isolation, loss of confidence. Why medications? Nice guideline. 56. Because a lot of people with multiple long-term conditions will be on a lot of medications, and we know that there is a tipping point at which some of that becomes burdensome. It's different for different individuals, and this very much comes down to having a tailored care planning discussion with an individual. There are many ways that this can be delivered in a primary care setting. This is not wholly the responsibility of general practice. What do we plan to do with this? We're going to use this data to feed into right care to look at how frailty is being managed and behaving across the system. And I strongly recommend that you look at this because it gives us the first opportunity to plan a pathway for frailty, and I think there's much more to come to this, many more data points that we can feed into this to look at how we effectively manage this condition over a period of years. Key parts of older people's services that I'll just highlight to you include the whole spectrum of frailty management. This is not just about prevention, as I've said, it's also about dealing with the consequences of frailty when people are most in need. And that would include acute frailty services in a hospital setting, organising rapid de-escalation of those not in need of acute hospital care but in need of rehab and recovery, right the way through to end-of-life care. And I think frailty care does align very well with the ambitions for palliative care and end-of-life care because whatever the cause of that person's deterioration, we know that inevitably those with severe frailty will progress towards the ends of their life. If you want to know what we've achieved so far nationally, please do look at the NHS England website. Again, to summarise that, we are economically modelling this. We want to know how much frailty is costing the country. We do not know this at the moment. That's hopefully going to be published later this year based on the Leeds and the Kent data sets. We're also working with Right Care to refine the frailty pathway and the multimorbidity pathways. And we intend to look at how community services are being organised to deliver some of those responses, as I say, outside of hospital. Thank you.
Thanks, Martin. I appreciate that it was a bit of a whistle stop, so I do appreciate it, and there is so much in that presentation. Do we have any sort of questions? I can see Adrian has got a hand, so Jen, if you could you introduce yourself as well, Adrian, please? Oh, hold on. Yeah, go ahead.
Hi, Adrian Hayter. I'm a GP, a clinical commissioner, and I work in the Frimley Health System, SDP. So thank you for your talk. It really kind of brought us bang up to date in terms of where frailty is, and I think from a GP perspective, this is actually where our heart is in terms of identifying populations which are most at risk and doing something about them and being able to work with that. So just wanted to describe, in my practice, we've got 12,000 patients. On the EFI, for those people possibly living with frailty, 250 or so will be severely frail, 600 in the moderate category, and then in the mild category, about 2,000 patients. So kind of quite big numbers for a practice. Not this winter, but the winter before, we did a scheme which looked at identifying people from the EFI with frailty and doing some interventions. One was around medication and actually doing some real work around kind of doing that. Second was around social care and actually kind of getting some social interventions, so connected into some other stuff. And then the other thing was around kind of just looking at all their long-term conditions. So, and actually we presented 12 patients out of that with a mixture of mild, moderate and severe frailty, and showed that really made some differences to those 12 people. However, that was a huge amount of work, together with the unplanned admissions work, together with all the other stuff that we do for QOF, to be able to work in the practice. Now we're faced with the new kind of frailty contract. I think there's a lot more that we can do. Our partnerships kind of started to rethink the way that we do things. One is around support for carers, and we've got a very older population in my practice, more than the normal average for the CCGM for population. So we're actually targeting the kind of social bit to support the carers, and we've got carers who are in their 90s, so that kind of shows kind of how much and there's a big piece of work going on there. But what we're struggling with, I suppose, is the manpower and the resources to be able to bring the next step of work on. And I just wondered, from your perspective, around up and down the country, how are general practices changing to kind of address the issues of frailty? Because it's a big question for us in our practice, it's a big question for us in our CCG, and it's a big question across the STP. And the STP is using the EFI as a population-based tool to be able to map out frailty in the Frimley STP.
Well, thank you very much for engaging with it early, and I would encourage everybody to do that. This is, as you said, it's a population management tool. And I'll go back to my earlier comment, which is that think very carefully about what's in front of you and choose wisely. I think, just to give one example, yesterday I was at a meeting of the Northern NHS, and the intervention that was being pushed very well and is now again on my Twitter feed is to look at falls prevention. So how do you do that? How do you give somebody a falls plan? In East Lancs they're doing it on a tea-towel and giving it out to people at risk, and that's it. And it does appear that you can make a difference. Where this has been done in other parts of the world, for instance in New Zealand, in Canterbury, there is evidence that having a brief intervention in a community setting to take down mats, sort out trip hazards, medicines review, and for those people willing to sign up to it, put in a strength and balance training exercise programme for up to 12 weeks. If you want to carry on, good for you and pay for yourself. That significantly reduces the impact on the urgent care system through falls, through fractures, and improves outcomes from things like your fractured neck or femur pathway. So understand your local population demand. What we've done with the contract is really to ensure that we get as best coverage as we can to at least understand and highlight where frailty sits in each local population, each STP footprint, and then to leave people to decide how best to intervene. So we've been very minimalistic around the interventions that we require in the core contract, ask them if they've had a fall, and also look at their medicines, because we know there's some evidence that sits behind that in terms of efficacy. Beyond that, I think it very much depends on what your local priorities and preferences are, but at least it gives you a common currency to understand your population burden locally, and it will vary across the country.
So I think that's all we've got for now. I'm sorry, I do apologise, and I'm just aware of the time, so really thanks to Martin. I think another good point there about the Christchurch, Canterbury, New Zealand example might be quite interesting if we could try and draw some of that out for some further information. Maybe we can link that up. So thank you to Martin, and thank you also to Susan. So should we give them all a round of applause? Thank you.